5.5e, conduct intraosseous needle insertion. Apply PPE precautions. Assemble equipment, supplies, and prepare patient for procedure. Student is able to landmark the correct insertion site for the adult patient, proximal humerus, distal tibia, proximal tibia. Student is able to landmark the correct insertion site for the pediatric patient, proximal humerus, distal tibia, proximal tibia, and distal femur. For the purposes of this skill station, the student will be examined on the proximal tibia insertion site, landmarks correctly using the tibial tuberosity, measuring 2 to 3 fingers width below and to the medial side of the tibia. Prepares the site using institutional protocolar policy, circling outwards. Choose appropriate needle according to the patient age and size. Prepares supplies, prime connection, and IV line with stopcock. Attach needle set to EZ-IO power driver and remove safety cap from the catheter. Insert the IO needle through the soft tissue towards the bone at approximately 90 degrees. Direct the needle away from the epiphyseal plate in pediatrics. Push the needle through the skin until the tip of the needle touches the bone. 5 millimeters of the catheter, at least one black line, must be visible outside the skin. The most accurate determinant of correct needle selection is use of the depth markings. Black depth marks on each catheter function as depth measuring guides to determine soft tissue depth overlying the bone. When the needle contacts the bone, squeeze the trigger and apply moderate, steady pressure, allowing the needle set rotation to penetrate the bone. Note, if the driver should fail, disconnect the power driver, grasp the needle set hub by hand, and advance the IO into the medullary space using a twisting motion. Advance the needle set and release the trigger. Pediatrics. Release the trigger when a sudden give or pop is felt, indicating entry into the medullary space. For adults, advance the needle set approximately 1 to 2 centimeters after entry into the medullary space. Stabilize the needle at the hub, disconnect the driver, and remove the stylet from the needle, placing directly into a sharps container. Use of a commercial stabilizing device is recommended, such as the Easy Stabilizer. Place the stabilizer over the catheter and adhere to the skin. Attach a primed extension set with a stopcock firmly to the hub. For patients responsive to pain, consider 2% preservative and epinephrine-free lidocaine, following institutional protocols for amount desired. Attach appropriate size syringe to stopcock with normal saline flush. Prior to flush, aspirate slightly for visual confirmation of bone marrow. Infuse 5 to 10 mL of saline, 2 to 5 mL for pediatrics, with the syringe and ensure easy passage of fluids. Check for infiltration. Confirm catheter placement with the following recommended methods: stability of the catheter in the bone, ability to flush the catheter, and adequate flow rate. Attach IV tubing to the stopcock and infuse fluid at the desired rate. Reassess patient, monitor insertion site frequently for extravasation. And describe document and patient care required with IO infusions. Intraosseous removal. Remove the extension set from the end of the IO and adhesive dressing securing the IO. Attach a Luer lock syringe to the hub of IO catheter. Withdraw the IO catheter by applying traction while rotating the syringe and catheter clockwise. Maintain axial alignment during removal. Do not rock or bend the intraosseous catheter. Once removed, immediately place syringe catheter in appropriate sharps container and dress site per institutional policy or procedure.